I get 100 calls from general dentists when there's a case with open apex. So diagnosing a tooth with open apex is another part, but then treating the tooth and which treatment option is right for that tooth is something we all should know as dentists. In our UG days, we read about apexogenesis, apexification, we just by heart the definitions, but we don't really get to see the cases with apexification and apexogenesis. There's a lot of theory regarding apexification, the apexogenesis and their differences, but I want to give you some insights as a clinician. What's some basic criteria that you should know for diagnosing a case with open apex, and should you go for apexogenesis or apexification? So starting off with apexogenesis. Genesis means growth, regeneration. So in apexogenesis, you see the root apex growing. That means you create a favorable environment in the tooth root so that the root grows further. In apexification, there is no such growth of the root. You are just creating an artificial physical barrier at the apex of the root so that the periradicular tissue is not inflamed by your root filling materials, as well as you improve the strength of the root, which is already weak because of the thin walls of the open apex. Now, how to choose a case for apexogenesis or apexification? So if you think the patient is young, healthy, and the trauma is not too long ago, that means it's a recent trauma where the periapical tissues are relatively healthy. In such cases, you can attempt for apexogenesis. There's a higher chance of success in such cases. For example, if there's an 8-year-old patient who came with broken tooth, the pulp was exposed and it's been like that for a month. Now, that case, you cannot do immediate pulp capping. So you have to remove the pulp, which is infected obviously because of the saliva that has entered inside, and now you clean the root, you put your medicaments, stem cells which are in the apex, fill the root canal. That favors growth of the tooth root. Whereas in apexification, you do that mostly in cases where regeneration is not possible. That means maybe the patient had trauma a year ago, 2 years ago. There's a periapical lesion which is very active. There's pus and discharge. So what would you do? If the lesion is smaller in size but the root apex is wide, then you disinfect the canal, and once the discharge is gone, the infection has subsided, you fill the root apex with a biocompatible biomaterial such as MTA or biodentin. Now once you pack the MTA or biodentin at the apical third, then you fill the remaining root with your filling materials. So why should I use a biomaterial, and why can't I fill the root apex with my GP? So it's important to know here that the walls of a tooth with open apex is very thin. They are incompletely formed. Maybe in your 2D X-rays, you might see some thickness of the walls, but when you see the 3D view of the root, you can find some defects in the wall. When you're radially condensing the canal, you might be inflicting some cracks in the root, and it might further lead to fracture of the root. So it's important to preserve the structure which is already there. This way we can ensure that the periradicular tissues are safe with a biocompatible MTA and the canal is filled, and we can prevent further infection by this double barrier. Hope this gives you some clarity about what's apexification and apexogenesis. So next time you get a case in your clinic, you would know which option to pick.